Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy.
Right.
What's today? Infection?
I'm ready, man. I'm ready. Yeah. I looked at the sheet. Who else we got? We got Reed, Manuel,
Yeah, Colin
Christina, Jean.
Colin texted me he wouldn't be able to make it today, so he was a last minute scratch.
Gotcha.
I don't know if anybody else wants the infection case.
Yeah. Figure out how to share my screen. Oh, there's share.
I was kind of thinking this morning, like a lot of people they get through residency and get into studying for this exam, and like you already went through the hardest part. You went through 4 or 6 years of just basically indentured servitude. You were a warm body, like doing the work, and this last final part of just studying for boards and articulating what you know. Yeah, it's tough, but if you just view it like a fight and take a deep breath. Most people pass this. Like if you go to the stats, something like 76% of people pass this thing.
Good. That's encouraging.
Yeah, it's somewhat encouraging, right? Like at least at least the odds are with you. If you got past the qualifying exam, like let's go to stats fees timelines. Yeah, hold on. I'm going to share my screen real quick.
Ryan, in the meantime, can you give me a hint? I think I was able to share a screen before, but now I'm having trouble.
Oh, you know what? It might be the options here. One second. Hold on. I gotta.
Okay. After you do your thing.
Yeah, I have to do that. Here we go. It should pop up now.
Options. There's share content.
First time candidates.
But yeah, let's see what you got.
Out of 260 people taking it, 212 passed it. And that's from 2020. That's not this past year's cycle. Repeat candidates, half of them passed it. And you do see some repeat candidates, even in Nashville. And there were a couple in our last study group too, but everybody passed. It's just practice. Out of 322 people taking it, 244 people passed it. It's a 75% pass rate. So as long as you're practicing.
I'm glad I'm in this study group.
As long as you're practicing and doing something, like you'll pass it. I think it happens probably with the people who try to go it alone. That's my best guess. But
anyway, this is gonna be good. Yeah. Once I get my screen share so I can present the damn case, that would be awesome, man.
Yeah, did it not work?
Let's see. So I'm looking at my screen. There's a share content button.
Yeah.
Screen. There you go. Okay, screen.
Yeah.
Okay. So broadcast screen.
And the
broadcast.
Real question for today: who wants Serge's infection case?
Yeah, I can do it. It doesn't matter.
Yeah, Gene. Gene, how you doing?
I'm good.
Oh, what's up, Greg? It's the birthday boy.
Damn, my hat hair is strong right now.
Unless Greg wants it. Because I did an infection with you like 2 weeks ago, but I don't care.
Yeah, this might, I don't know. Serge hasn't shown me this case, which is.
Can you guys? Yeah. No.
It's good.
Can you see the screen?
Yes.
Yeah, we can see it, man.
All right. So who's up again? Who's?
I think Jean said
who's
she
going
got
through this?
I'll definitely. I can do it. I don't know if anyone else wanted to do it. That's why. That's fine to me.
Jean. So you got this. So what time is it? Okay, 9:08 on my clock. So Friday afternoon call. 9:08. Okay. So we got the Friday afternoon call from your good referral. He has a patient that with a painful tooth number 30. Planning to do root canal, starting on clindamycin, but his cheek just started to swell a little bit. Do you think you can save the tooth? He says. So that's the conversation on the phone. What do you tell him?
Hold on a second. My screen's like partially blocked right now. So you're gonna go. Hold on. Let me just read this again. Painful tooth number 30, root canal. We already know that he's been on antibiotics. All right, let's go through medical. Can we get his medical history?
Yeah, you got.
How old is this guy? Sorry.
Sure. Yeah, this how old he's 54 years old.
Okay, perfect.
He has best medical use of hypertension, gout, COPD, CHF, stroke, kidney disease, and dyslipidemia.
Okay.
He's on currently clindamycin, warfarin, blood pressure medicines. He's got no allergies. He's a smoker and a daily alcohol user.
Okay.
Okay. What do you want to do next?
How long has he been having the swelling for?
Oh, about 3 days now.
Is he having, what are his symptoms now? Does he have any dysphagia, any, dinophagia?
Oh, I don't know. Dentist says, I don't know. Like, I haven't checked for that. I'm just trying to get those tooth, like what kind of.
Okay, so you're going to do a physical exam.
All right. So should I send? He said, should I send him to your office?
Oh,
you're still on the phone.
He's not in your office right now?
No, you got a phone call. Yeah, it's just still on the phone.
Oh, I'm sorry. I totally missed that part. I thought he's like in your chair.
I don't know, man. Got to make it realistic.
I mean, sure. I would have him come to the office.
Okay, good. The patient comes in. Yeah. So he says, this is the guy. He presents to you. Says, yeah, just the tooth start to hurt, and I don't have trouble really opening my mouth or swallowing or breathing. So, yeah, what's your next step?
So I'm going to do a physical exam. So you can here, it looks like it's extending below the inferior border. It looks a little bit erythematous. In the submandibular area. You're going to check for MIO. You're going to check for floor of the mouth swelling, uvula deviation, just fluctuance in the vestibule or anywhere around the tooth. And I would definitely, since you're in the office, CT scan with contrast is not possible right now, but I would get at least a pan or a CBCT.
Okay, good. So you do an exam. His temperature's 101. His respirations are normal. SpO2 is normal. Blood pressure is within normal limits for him. He's got that erythematous swelling that's fluctuant on the right cheek, border mandible not palpable. He's got dry mucous membranes. He can open his mouth just fine. Non-elevated floor of mouth, purulent discharge around tooth number 30. His eye exam is normal. He's got a little mechanical click in his on his auscultation of the chest due to history of aortic valve replacement, and otherwise his exam is benign, and that's his Panorex.
Okay. So I see. It's hard to say. He definitely has multiple caries on dentition. Missing number 2. Maybe missing. It looks, maybe could be a root tip. It looks funky to me. He has definitely carious, non-restorable number 19, and very questionably restorable number 30. And they both have PAP lesions. And it's a panoramic image of diagnostic quality.
Okay, good. So what do you want to do next?
So I would consent the patient, or actually, sorry, you said he has, I would consent the patient for extraction of the tooth. He doesn't have trismus, right? He can open all the way.
Correct.
So consent the patient for extraction of, I would extract both number 19 and 30 at this time. Okay. And do IND intraorally.
Okay. All right. What are your criteria for hospital admission?
So if the patient his vital signs are not stable, but in his case, they seem stable. He had a 101, which is very slight fever there. And includes if he had any airway issues.
Okay.
Which he does not have. It just seems like it's very localized to the area of the tooth right now. The only concerning thing for me is that it is kind of extending below the inferior border. But if we can get the tooth out, which it seems like we have access to right now, and there is no airway edema, floor of the mouth swelling, anything like that, that would indicate that this is like a true hospital emergency.
Gotcha. Due to his fever, dehydration, and multiple systemic issues, you decide to send him to ER for evaluation. What would you request ER physician kind of obtain for you to further your diagnosis?
So I would get a CBC, BMP. I would get a CT with contrast.
Okay.
I would go from there.
All right. So this is his labs. Can you interpret that quick?
So he has platelets of 480, white count of 19. BUN creatinine. Creatinine seems high.
Okay.
I don't actually remember the exact numbers.
Good.
All his other labs look normal though. His hemoglobin is hematocrit.
Okay.
Platelets are slightly high, but I don't think it's significant.
Gotcha. So the ER physician calls you back, says, his creatinine is a little too high to get a CT scan with contrast. What are your other options you can suggest?
You could do an ultrasound of the area to check for a collection. Okay. You could get an MRI as well.
Good.
Good. But those would be your.
Gotcha. So that ER physician was pretty much getting done with his shift. The new ER physician comes on and says, we'll just give the guy a little IV fluid bolus, and then we'll go ahead and get that CT scan with contrast. So to do that, what do you see?
I see a collection in the, let's see. It actually just looks like it's in the buccal space, in the right buccal space area.
Okay.
In both the axial and the coronal views. I don't see the bone structure right now because
any subcutaneous tissue changes you've seen?
Yes, yeah. There's swelling. It looks like there's rim enhancing around this collection.
Okay, good.
Yeah.
So what's your final diagnosis for this patient?
A right buccal space infection.
Okay. What are the contents of buccal space?
The contents? Do you mean like the boundaries?
No. What is inside buccal space? What anatomic structures are inside? You expect to find?
So you can expect to find parotid gland. It's bordered by the buccinator.
Okay.
You have cranial nerve.
Is it medial or lateral to buccinator?
It's lateral buccinator.
Okay. All right. So given the diagnosis, what you want to do next?
I would take the patient to the OR. You could do an oral intubation.
Okay.
There is no
anything else? I'm sorry, I'm just going to interrupt. Anything else? Any consultations you want to obtain from other services before you take patients to OR?
Oh yeah, it's true. He's very medically compromised. I'll probably get a cardio.
Okay.
Yeah.
Okay.
I would definitely get a cardiac consult. COPD, CHF, CVA, CKD. I mean, you can get a renal consult. You could get the a pulmonary consult. We need to make sure he gets pre-medicated because of this mechanical aortic valve. So if he doesn't have any allergies, we can give 2 grams of amoxicillin an hour before the procedure.
Okay. You, while getting a cardiology consult, you are waiting for, you go ahead and aspirate the contents with a fine needle and just send it to the lab while you wait. Or who knows how long it's going. That's the result you get on a culture. What kind of bacteria is that? Canella?
I don't know.
All right. What antibiotics would you suggest this patient be on, given this result?
You can give amoxicillin, targets Icanella.
Well, he's already on Clinda. Is that a problem?
I don't think Clinda is effective against Icanella.
Okay. All right. Cardiology verified the patient's prosthetic aortic valve is functional, well advised proper IV fluids to avoid fluid overload for the patient. During the case and hospital stay, they bridged his warfarin to subcu heparin. Okay. Describe the procedure that you'll perform on this patient once he's in the operating room and asleep.
Okay.
Go ahead.
Wait, did you ask me a question there?
Yeah. Can you tell me the steps of the procedure?
Oh, yes. Sorry. So I'd bring the patient to the OR. I would request oral intubation is fine. I would remove both teeth number 30 and 19 first. Okay. I would see how much drainage I get out of socket of number 30. If there isn't adequate drainage, I would make a stab incision in the buccal vestibule and used a curved hemostat to go down to bone until I find a pocket and encounter, the collection.
Good. You got the space drained, teeth out, patient did wilderness surgery. What's going to be your post-operative course, and how often are you going to see patient, and what are you going to monitor for?
So, I would put a drain there, considering that we're going to keep the patient in the hospital afterwards, just because of he's medically compromised and we don't want this infection to travel down his neck. So what I would do is I would have the patient, I would do serial exams, probably like 12 hours after, to see how he's doing. You're going to look for any changes in physical exam, any changes in vitals. You're going to keep track of white count. You're going to have the patient have a suction at bedside.
What if he continues to have fevers and purulent drainage on day 2?
I'm sorry, say that again?
What if he continues to feel malaise? Fatigued, there's purulent drainage, he continues to have fever. What would your next step would be?
Is this like the next day?
Yes, like post-op day 2.
Post-op day 2. I would probably get a repeat CT scan in addition to looking at the labs.
On post-op day 3, overall he started to improve, but on the post-op day 3, he started to have some right eye pain and diplopia.
Oh no.
You can describe your how would you perform a physical exam on this patient at this point?
I don't really understand what you're asking. How would I?
So
I would do a cranial nerve exam
on post-op day 3. Okay, good.
I would do a cranial nerve exam.
All right, you do your cranial nerve exam. You notice that he has got a right cranial nerve 6 palsy, mild proptosis of the right eye, and pain on movement. What's your most likely diagnosis here?
Cavernous sinus thrombosis.
All right. By what means could his infection have traveled from buccal space into the cavernous sinus?
Ooh. He could have gone through the facial. Could have gone through the facial vein.
Okay. All right. At the same time, lab calls back where they did the cultures from your OR procedure and they grew Staph aureus in a specimen. Would you consider any other additional antibiotics?
In addition to amoxicillin?
Yeah.
I'm not sure.
All right. Given the diagnosis that you just told me, what is going to be your next steps for workup?
I would get another. I could get a. I'm trying to think. Actually, you would get a CT, another CT with contrast.
Okay. All right. Well, what else? Let's say CT with contrast shows definitive coronary sinus thrombosis. Then what would be your what management would you expect to have to be done?
I would get a neuro consult.
All right. Patient says, "Doc, am I going to die from this?" What would you say to the patient?
Ooh, that's a tricky question. I mean, technically you could. I would probably, like, in terms of my management, I'd probably just put the patient on steroids. You wouldn't put them on, I don't think we would put them on blood thinners. I would get a consult for that.
So you tell the patient he's got certainly a chance of death, but you will continue managing him. Okay. All right. You're done.
Is that the case?
Man, that's it, man.
Hey, there we go. Claps for Gene.
Man, that's a tough case. I made it like dirty. I make it tough, and many turns into it on purpose.
No, it's good though, because it makes you think about the more detailed stuff, you know.
Yeah.
I thought it was a fair case, and they were even better answers too, Gene. It was good. It was good.
Yeah,
from like the Serge, I like how you threw in there from the beginning. There was like professionalism, like, because you received the phone call on a Friday afternoon, and
right.
But then you went into anyway. You can break down the case. That was my critique. I really like that.
I mean, I loaded it.
Wait, can I just ask a question? For Staph, you can do like Vanco, right, or like a cephalosporin.
Vanco is the answer I was looking for.
Okay.
Yeah.
What was the answer, Serge?
For Staph aureus,
yeah.
Usually put them on Vanco. Vanco is just such high risk of having MRSA.
Yeah, I just didn't want to. I don't know. Like, we were always taught, like, on the boards, like in our whatever patient care conferences, like, if you're not sure, just say I don't know. Like,
Yep.
Don't guess. So that's why I was like, I think it's Vanc, but
it's much better, Gene, because they'll start leading you down little roads if if you suggest something like
I was 75% sure, and then I was like, oh, I feel like I should just say I don't know.
Yeah. Just saying I don't know is perfectly fine.
Yeah,
it's perfectly fine.
So I mean, this guy is obviously super sick, and we're gonna go through, I guess, some potential questions they could ask. So, like, what things on his history put him at high risk of severe infection? So he's got CKD. He's an alcoholic. In terms of
hey, Serge, could you share your screen again, like to review the case?
Hey yo. I gotta sharpen my swords for the oral boards. I learned them from Patel, and he's the Lord. And I'm his protege. You know I'm gonna slay all these motherfucking questions today. Cause I got the sound bites. They're gonna make these old men go, ooh, ah, like some afternoon delight. Yo, I got these questions in my sight, and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.